K S Kumar.
Thanks, Dr. Giridhar, for including me in this instruction course. Combined retinal detachment also goes by the acronym of CTRRD, which means combined tractional rhegmatogenous retinal detachments. Among all the various causes of diabetic retinopathy which warrant surgery, probably the technically difficult one would top the list, and that would be a combined retinal detachment. Let us straight go to the clinical features. The patient may complain of a sudden drop in vision, but because these patients may already be having subnormal or suboptimal vision, the drop in vision may not be noticed by many, and it may be insidious too. It will have a convex configuration, but this configuration can be variable and pleat-like depending upon the extent of preretinal fibrosis. The only thing is these patients may not have the corrugations or the rugae that we see in a typical rhegmatogenous detachment. That is because of retinal edema, and because these eyes are mostly ischemic, one may not see those rugae or the corrugations in the retina. What is most important is this configuration is caused by the development of a break in the retina, and we need to dwell a little bit on these breaks. These can be obscured many times by media opacities, retinal folds, or even tissue, epiretinal tissue that is covering these openings in the retina. They may be slit-like, or they may be multiple and sieve-like, particularly if they are related to laser marks, or there may be ovoid tiny breaks along the vessels at the base of the fibrovascular proliferations, at the edge of laser marks, or it may even be a macular hole as a cause for combined retinal detachment. The geographic profile of the detachment itself is variable. It could reach the ora at least in some quadrants. It may not typically follow the Linkoff's rules, obviously because of the epiretinal tissue, as also the laser that might have been done in some of these cases. And occasionally one may have subretinal bleed and subretinal gliosis as well. Subretinal gliosis is particularly more common because these breaks are small, and the RPE, instead of coming onto the epiretinal surface, tends to form membranes underneath the retina. This is a typical photograph of a combined retinal detachment. One may not always be lucky to see the break, as can be seen in this patient. This is a wide-angle view of the same. What are the predisposing factors for a combined retinal detachment? Traction retinal detachment, long-standing, which may be extramacular itself, is a predisposition to combined retinal detachment. Heavy laser treatment, particularly in the situation of a vitreous hemorrhage, or at the edge of a TRD where the retina may be partially lifted, or laser over areas of superficial bleed, can induce breaks in the retina. Or it can be iatrogenic. You're operating on a traction retinal detachment, a pure case of TRD, but iatrogenic breaks in that scenario is fairly common, and it may get converted into a combined retinal detachment. Or it can develop after anti-VEGF injections also, as has been reported in some cases, particularly with the use of bevacizumab, because it blocks all isoforms of VEGF. And we, of course, I have no experience with pegaptenib, but because pegaptenib only acts on the VEGF A165 isoform, it's thought to not so much predisposed to preretinal fibrosis. And that has been called as the Crunch syndrome. We'll talk about that in a minute. Now, for our own discussion purposes, we can divide the combined retinal detachments into two varieties, either the central or the peripheral, or it can be associated with the active fibrovascular phase, or it can occur even in the late fibrotic phase. A typical case in point is this patient who had extensive new vessels on fluorescein angiography in his left eye. We did what we thought was fairly adequate laser, but a year down the line he bled again. We tried to do a pattern tightening laser, and with which the blood cleared up. 5 years after that, he presents just recently with a posterior pole TRD, which we were able to settle with surgery and silicone oil. So these are patients who can develop late as well. And this is an example of a combined retinal detachment in the scenario of active fibrovascular proliferation, as you can see in the top pictures, and these are the post-operative pictures. It may also happen in situations where we feel that the disease has quietened, has become quiescent with largely fibrosis, but there can be pulling up of the retina even in the fibrotic phase. What about the preoperative evaluation in these patients? One must carefully look for rubeosis, laser any untreated retina, because that will make the surgery easier and shorten the surgical time. Search for breaks diligently under magnification. This is very important. There may be a tendency to believe that the retinal breaks need not be identified. We are anyway going in, we can create an iatrogenic break for endo drainage. As much as possible, we must try to identify the breaks, if not preoperatively, at least intraoperatively, because the more the number of breaks we create, each break individually increases the chance of a recurrent detachment. So there should be a very high threshold for creating any new breaks intraoperatively. About the role of preoperative Avastin, yes, in highly vascular combined retinal detachments, one could give that to reduce the neovascularization, with the clear caveat that these patients should be taken up for surgery no later than 5 days. Else, these patients may develop what has been called as the crunch syndrome, whereby the neovascular tissue regresses, but the fibrotic component of the fibrovascular proliferation becomes thicker, and the tissue planes are difficult to identify. And if the patient has comorbid conditions such as diabetes, diabetic nephropathy, or has some other issues which makes deferral of surgery required, then you would have lost the opportunity to go in with a vitrectomy, and that is the situation where probably this could be counterproductive. About the OCT biomarkers, outer retinal microarchitecture is more prognostic of the likely visual outcome, and even if the media is clear in these patients, we may take additional help of B-scan and an OCT to identify the tissue planes where we can initiate the surgical processes. The role of preoperative Ozurdex, some have used preoperative Ozurdex as well, as opposed to bevacizumab, for the various advantages that the steroids give us. The basic tenets in managing CRDs are just the same as was enunciated earlier. Media clarity should be ensured, and if this means removing a cataract that is also interfering with our vision, we must do that, because we are only as good a surgeon as we can see, and these surgeries may take a long time with a lot of maneuvers, intraocular maneuvers involved. So ensuring media clarity is primary, then clear all the opaque or even the clear vitreous as the case may be. Relieve anterior-posterior traction by truncating the peripheral vitreous cone to start with, and then go on to remove the tangential traction, as has been discussed already. Adequate hemostasis is very important. The maneuvers with which we can do that, we will come to it in a moment. Identifying the breaks are very important, as I alluded to already. Don't create any, or at least not many. And retinal reattachment, ensuring retinal reattachment is key, because these patients are at very high risk of developing postoperative rubeosis, and if it means due to intrinsic shortening of the retina, retinotomies or retinectomies have to be done, then those also have to be done. Endolaser and appropriate tamponade. Some intraoperative nuggets, no standard format can be given for a given case, because each case is a learning experience, and each case teaches us something. So we may have to be individualizing, improvising on the table, and ability to think quick on one's feet is very important. Basically, it involves dealing with the traction retinal detachment, even though it's a combined retinal detachment. So one cannot afford to leave the traction behind and try and reattach the retina without dealing with the traction. Recognizing the break is possible under high magnification or by the phenomenon of Claren, which we are all familiar with. Because of the higher viscosity of the subretinal fluid, fluid-air exchange may not suffice to drain the subretinal fluid in many of these cases. So a fluid-fluid exchange, which we will discuss in a moment, is the way. And when you do that, you can see sclerin. Reattaching the retina is the next step. You may use either fluid-air exchange or a fluid-fluid exchange or a perfluorocarbon liquid to do that. And then endolaser and appropriate tamponade. Role of adjuncts: if there is unrelieved severe anteroposterior peripheral traction, particularly in a phakic eye, one may use buccal. This is again an individual choice. Perfluorocarbons help in several ways. It helps to stabilize the detached retina during dissection, allows lower laser power in intrinsic retinal shortening. Many times when you do a fluid-air exchange, the retina is well attached, but when you try to do laser, you're not getting sufficient burns even with increasing the laser power. So in those situations, you get a really tight adhesion. And ILM peeling in CRD with full thickness macular holes also is a situation where adjuncts help. I will quickly go through the short video that I have. Differential diagnosis, one may have to differentiate it from a traction retinoschisis itself. A concave configuration, despite the presence of a break, would probably suggest that it's just a traction retinoschisis, but these are the eyes which have poorer prognosis. And RRD in a case of PDR. Impact of newer instrumentation has already been discussed. Intraoperative OCT is a useful adjunct which gives anatomic feedback. And these are some of the cases. I think my time is up. I'll go straight away to the video. I'll just take 2-3 minutes to highlight some of the facets of managing combined retinal detachments. The basic tricks are, as I said, you may have multiple solutions to the problem. I think, can I take a minute, Giri? Or you may have to think out of the box when you are confronted with a difficult situation. The first step would be, of course, to clear the media opacities in the form of either I'm not going to dwell on that a lot. Then we have to deal with the posterior hyaloid phase, and you may, in those cases where you feel the posterior hyaloid is easily amenable to removal with a vitrector, you use suction and try to go around circumferentially as far as possible. Of course, these are not possible in every case, but each case has to be individualized based on the pathoanatomy. Then we come to the epiretinal proliferations themselves. With the small gauge, high-speed cutting instruments, you can do this with the cutter itself, as is being shown. And if there are any stumps that are really very adherent, you can then use the peeling technique. But most often in diabetic combined retinal detachments, you must be very careful about peeling, because these membranes are very adherent and vascular, and cutting with scissors or with the forceps is rather suited, rather than trying to be more bent on peeling. This shows the residual membranes being chewed up with the cutter. And I am not going to show bimanual, so that is the brake which we were discussing. That's the tiny brake which we were able to identify. I'm sorry, there is a lot of blooming over there, but that's the tiny brake. And then you assess the degree of adhesion of the fibrovascular tissue to the subjacent retina by trying to elevate. If the surrounding retina is ischemic, as evidenced by occluded vessels and atrophic retina, and you are not getting a lift, I'm showing only the unimanual surgeries which we used to do, because Giridhar will discuss about bimanual. The useful technique that we used to do those days was use the light pipe itself for counter traction, and that will really come in handy in some of these tough adhesions. See the second hand with the light pipe itself is giving a counter traction and allowing us to go into the cleavage plane to remove these epiretinal proliferations. Of course, bleed under the subretinal, bleed under these membranes is an issue to contend with. I have only about a minute or so. I haven't edited that part because I thought we must focus on the area of attention last, as Mahesh was mentioning. Finish up with whatever is possible before you can do, such as laser, treat the rest of the retina, and come to the difficult part last. This shows the ectodiathermy being done along the bleeders from the tissues that we removed, and those stumps which are very hard and not amenable to removal by the cutter, we remove it with the scissors, and this is the fluid-fluid exchange that I was referring to. We have not put in any air, we are just using the suction with the vitrector and trying to get as much as the subretinal fluid out as possible. And if there is any residual tissue left over the disc and if it is not very adherent, it's better to get that off, as is being done here. Then you endodiathermize the brake. And the point about removing all traction around the brake, which we were discussing, is very important, not to shift to another area if we develop a nitrogenic brake in the area of dissection, because that can cause a combined or a rhegmatogenous detachment to obscure the rest of the surgery. And when we remove all this traction around the brake, you can see that the brake limply falls back on the retina. And our surgery, many times one will have to get used to managing under suboptimal visualization, because intraoperative blood is a constant menace. And when there's oozing, it's better to address that issue quickly, otherwise we may be we may have an issue on hand where the whole that becomes another surgery by itself, removing the epiretinal blood. Then we do the laser and then the fluid air exchange and tamponade. Thank you very much for your patient hearing.